Good afternoon, everybody.
Good
Welcome to
afternoon.
today's talk. Today's session will be this is on the occasion of World Liver Day, and we'll be talking today about liver wellness across the lifespan. And with us, we have a very famous panel. We have Dr. Arvind Sani, who's from Fortis Mohali, Dr. Ajay Bhalla, who's the director of Fortis Noida. We have Dr. Kishore, who's from Fortis Bangalore, and Dr. Rinkesh Bansal, who is in Fortis Gurgaon. And we are waiting for Dr. Gaurav to join us, and he will also join us soon. He's from Mumbai. And we'll be speaking about liver health across the lifespan. And we start from small baby to as we grow in youth and as we grow older. And let us start with what happens to the change. What happens? What happens to the liver as we grow from infants to as we grow old? Rinkesh, Dr. Rinkesh, will you take that? Do you
Sir,
think anything changes in the liver? What are the illnesses which will be there in younger children?
yes. So basically, good afternoon, everyone. Generally, the liver disease we encounter in younger age are neonatal cholestasis, then biliary atresia, extrahepatic biliary atresia, then sometime uh, the the cholestatic or non-cholestatic hepatitis. These are the things, and some metabolic liver diseases for which, in fact, we may require liver transplantation also. And these are the common things we encounter. Basically, I'm not an expert because we generally don't see
Yeah,
as
so
a
very true. So
we
one of
are
the
adult.
important things you mentioned, but along with
Sir.
this, I think there are two more things which we should cover. First is hepatitis B. Often in mothers have hepatitis B, and we worry
Yes, sir.
about what happens to them, the children. The second thing is there is a growing amount of obesity happening in young children, and fatty liver related to that is also something to consider. So let's start with hepatitis B, and we have a lady who's hepatitis B positive. She's HBsAg positive, which is the marker which we use for hepatitis B. Along with this, she's pregnant. So, what should be our advice so that we decrease the risk of infection to the baby when the baby is born? So, Dr. Kishore, would you like to take that?
Yes, sir. Good afternoon, everybody. I think perinatal transmission of hepatitis B is an important topic, and I think it can be prevented in the modern era. So, the first advice I would probably give is to reassure the mother and say that she should continue the pregnancy. And I think we should do a hepatitis E antigen to see if the mother is actively infective, and also do a hepatitis B surface antibody to see if she is immune, and also a core antibody. And I think in the perinatal period, we should probably during the time of delivery plan immunoglobulin, and maybe once the child is born, check the serology and maybe vaccinate the child. So these are some things that I would think of, sir.
So, any of the panel is welcome to join in if they want to add anything more
Yeah,
about what
Dr.
Dr.
Pankaj, yeah, Dr. Pankaj, we would do a HPV DNA also to quantify the viral load. If it is really high, the chances of infectivity or perinatal transmission will increase. So that is important. Then, based on these parameters, basically the infectivity and the degree of viral load, even in the third trimester or after 28 weeks, sometimes a deferrer can be used, antivirals can be used to decrease the perinatal transmission. And regardless of the serology, HBIG plus the hepatitis B vaccine, three doses must be given to the newborn baby also.
Dr. Rinkesh, if you put
Sir.
yours on mute till you talk, because I think there's a little background sound from where you are. So, yeah, that's nice. So whenever you talk, please switch yourself phone on, your unmute yourself. So, what points which have been raised are very true. There is a huge prevalence of hepatitis B in our country, and one of the important things is vaccination. and prevention of mother to child transmission. There's a role of giving tablets which to decrease the prevalence from in the to decrease the infection in the neonate, and depends if the viral load is very high, they'll be started on tablets and they'll be given immunoglobulins as well. So if these children are hepatitis, if the child does get hepatitis B, what would be advice you would give to that patient, to the parents? Now the child has become hepatitis B positive this after childbirth and is 3 years old. Dr. Bhala, what would be your advice to this parents?
Well, these children who do tend to be positive, acquiring the disease from the mother, tend to remain positive for a very, very long time. Their viral loads will remain high, and parents have to be made aware that this child is going to have a persistently high level. All the antivirals are not something which we would recommend at that younger age group, and they'll have to be serially monitored. The liver functions will have to be checked, the viral loads will have to be checked, and they have to be screened for hepatitis C, because these are immune tolerant patients. They're going to have very high viral loads, and it's only going to be at a later age when they're older that you can think about treating them with antivirals. So parents will have to be made aware that this is a disease which, like unlike in adults, where out of 100, 90% of them would clear the virus, here in infants, if they're less than one, more than 90% will persist with the disease. And if they
Very
acquire it later, they will. The incidence is like very high for them to be, have persistent chronic hepatitis B.
Very true. Our prevalence of hepatitis B is very high in our country. 2.7 is percent is the estimate. So we have millions and millions of people with hepatitis B. And vaccination and prevention of transmission is an important part in controlling these people. So if the patient does get hepatitis B, what is the age group at which they are likely to get liver disease? Dr. Rinkesh, would you like to take that? And when would you like to consider treating this? Now he's become a young adult and he has hepatitis B. He's 30 years old. He's got hepatitis B. Dr. Rinkesh, you're on mute.
Yes, sir. So basically, around at the age of 30, we need to see whether the patient develops some chronicity or not. And if there is a evidence of chronicity, we should treat these patient. At the same time, we should check with the SGPT along with the HBV viral load. And there are the criteria in presence of E antigen positive or antibody positive. According to them, we should treat them if they follow the criteria.
So if they're active and young, we would not treat them. But they're active and they're older, and there are different guidelines talking of what the age of cutoff would be. So, Dr. Arvind, what would be in your experience? What age group would you be treating these people, even if they are not they are replicated, but their liver enzymes are normal?
Dr. Pankaj, I've gone through a number of articles. Simply, some articles do suggest that don't wait for the SCOT and SCPT to go on the higher side. If in doubt, one can consider liver biopsy. We can do a fibroscan, and some studies have clearly shown only a persistently high elevated HPV DNA. There is increased risk of HCC. So some patients have been treated. This may be a gray area, but there's something to be kept in mind. One always should not wait for the textbook kind of indications. I would have a slightly low threshold at the age of 30 in terms of fibroscan, in terms of clinical features, in terms of clinical assessment of fibrosis, maybe plus minus biopsy, and the persistently high HPV DNA viral load.
So, so less and less of us are doing biopsies now. I wonder how many in the panel are still doing too many biopsies for hepatitis B.
Less,
We are
less.
using fibroscan as a surrogate marker for liver fibrosis. So anybody else routinely doing biopsies? I think the only place where I do a biopsy is if we suspect there is a comorbid condition. For example, the patient has raised autoimmune parameters are positive. And probably those are the conditions where I would do a biopsy. Anybody else?
You're right. Autoimmune hepatitis is the only one where you end up doing biopsies. Not for others. Fibroscan, I guess, elastography is working well.
So, like Dr. Arvind has said, even if the liver enzymes are normal, but very high replicative status, fibroscan is normal. What is the age cutoff at which you will say, despite everything else, we will treat this patient? Dr. Ajay? What would be your take? I mean, there is obviously going to be a difference of.
I would take anybody above the age of 18. There was a time when we had pegylated interferon available. We could have used it even at an earlier age. But here, the with the new antivirals that we are going to be using, whether they are NAs, nucleoside analogs, or nucleotide analogs, these are all going to be used. TAF also above the age of 18, I would be comfortable using in case indicated.
So we are looking at the indication. Enzymes are normal, fibroscan is normal, DNA is 5,000. Age is
And it's a
25.
patient with E negative. Yes, I would definitely would start treating that patient.
Okay, so we will often treat people. There's a school of thought also of treating almost all adults. It also has an additional advantages of decreasing transmission. So, what would be the advice to the family members if there's one adult who's positive? Dr. Kishore, welcome. Dr. Gaurav, welcome.
Yeah, hi Puri. Sorry, I'm traveling and
Not to worry, not to
sorry
worry.
for
We
the
will
late drive.
we'll keep
Okay,
you on the
okay.
road. We'll keep you on the road. Dr. Kishore,
Oh, sure, sure.
so what is the advice to the family members if a person is one person is hepatitis B positive? What should be the care for the other family members?
I think we should first screen all the near family members for seropositivity. So I would uh, suggest that the close family members and next of kin be screened for hepatitis B. And if the patient is infective, then they should take usual precautions to prevent transmission through body fluids. Still, the patient is non-infective.
So, what would be the vaccination strategies, and how many people do we need repeat vaccination for somebody who has already been vaccinated in the past, Dr. Gaurav? You just tell the audience what would be how many doses and when will you repeat? Can't hear. Dr. Rinkesh? Dr. Rinkesh, can you hear me?
So
I think
I'll take that, sir. I think the hepatitis B vaccination, the usual schedule is 016. Immediate after 1 month and after 6 months. Generally, hepatitis B vaccine is believed to give a lifelong immunity. So booster doses are rarely required. But I think if the anti-HBs titer is less than 10, then there may be a case to take a booster dose in people who are at high risk of exposure.
so. Routinely, we are not only in people who are at high risk of exposure,
Yeah.
like medical, paramedical. Those are the people where would be required. Now, let's move away from hepatitis B. Let's move to the sister virus, hepatitis C, one which troubled us for years and years, and we gave so much pegylated interferon, expensive drug with poor results, and and often frustrating because they keep getting injections, keep getting side effects, and the patients would curse you and not get better. Everything has changed. Hepatitis C was prevalence in India is about 1%, and we are seeing less and less of hepatitis C. What is the experience of the other people in the panel?
I
Dr.
think
Pankaj, in Punjab area, we are still seeing a lot of hepatitis C. In fact, after alcoholic liver disease, we are seeing number two as hepatitis C related problem. In certain areas of Punjab, certain areas of Haryana or Hisar belt, the prevalence is very high.
So, what is the
Still, we are
mode of
seeing a lot of
transmission in that
hepatitis C.
area? In that belt, what is the
The
mode of transmission?
mode of transmission is these intramuscular injections, so-called takat ka tika. They are taking the number two is the dentist basically via the dental practices and taking unsafe intramuscular injections basically.
So, but despite all that, overall, we are seeing that the prevalence is much less.
Yes, yes,
Punjab,
overall, but still
unfortunately,
it's
has had a
very
very high
obvious.
pocket,
Yes, yes,
but we are seeing less and less of newer cases. We are now seeing cases who are
yes,
already partially treated or
yes.
coming on follow up. What is the prevalence in Bangalore of hepatitis C?
Sir, my answer will be a bit biased. I'm a surgeon, so I don't see patients upfront in the OPD of hepatitis C. So all the
Okay.
hepatitis C patients whom I see are patients with HCC. So
All
they
right.
come for evaluation. So mine may
So,
not be the best of answers. But
okay,
we do
very
see
so.
hepatitis C.
Very true. So we are, if but we will come back to you for all the transplant questions which will
Just
go
to
through.
add, Pankaj, in selected groups like the patients with CKD on dialysis, the prevalence remains the same. I guess
True.
the high risk places, people who are hemophilics receiving concentrates, the prevalence remains the same. But we are seeing less and less because we've, I guess, treated so many of them now with the
Hmm.
directly acting antivirals that it's going away. It's just going away.
True. Newer antivirals have changed everything. Even people waiting for a transplant, many of them are sick, will say, go ahead, get a transplant, we'll treat you after the transplant as well, rather than waiting for the transplant. Okay, so moving away from hepatitis B and C, the next biggest challenge is alcohol. And the question which the whole world asks is, what is the safe limit of alcohol? How much alcohol is safe for people? Dr. Ajay?
Uh, uh, Alcohol is a toxin. There's nothing which you can say that you can safely have. I'm sure whatever you have is going to cause some harm. But if you look at it overall, only out of 20% of people who consume alcohol regularly actually suffer from serious liver disease. 80% of them still go scot free. So that's why the question comes: what is safe? I guess safety part. There are some guidelines from the British Medical Journal which they talked about that if you take for a female patient 10 small drinks a week with 2 drink free days, and male 14 drinks with 2 drink free days may be a safe limit. But then remember that all these are safe limits for patients not to have serious liver disease. Even those who consume this amount will definitely have fatty liver. So there is a demarcation which is going to be there. According to me, there will be nothing like a safe limit. Alcohol will definitely cause some liver damage, which may be just trivial fatty liver, but not a serious kind.
So significant liver disease would not usually happen in people in who are having up to 2 or 3 small drinks in males and 1 to 2 small drinks in females. But that is open to question. It's open to question because if they are obese, if they have hepatitis B, hepatitis C comorbidities, then even these are not safe. So, but
Absolutely.
I think alcohol. The biggest problem alcohol is quantifying the intake. How many people actually go ahead and use a peg measure? Nobody does. They say we have one drink, and one drink may be a small peg, maybe a Patiala peg, but something which goes on in Punjab is there's something beyond that, I guess, as well. Okay. So I think it's very difficult to quantify alcohol intake. So, Dr. Rinkesh, would you just tell us what are the alcohol-related liver damages that we see, and what would be the advice? Can the patient just decrease alcohol and get away with it, or should he stop alcohol totally?
So, in alcohol-related diseases, alcoholic hepatitis, alcoholic liver disease, chronic liver disease, these are the diseases which happens. Obviously, in alcoholic patient, we should stop alcohol. So, there is a, in my opinion, there should not be like advice that you should reduce the dose. No one can reduce the dose. So I think it's a complete abstinent, though there is chances of withdrawal, but I think they can be managed. But I think we should stop completely alcohol. Then only we can save the liver.
So another issue, which many of these people go on to get acute alcoholic hepatitis, leading on to transplant. And there has been a lot of debate on transplant, and we have two eminent transplant surgeons here. And let me ask them the questions as to what their views are on transplanting patients who have severe liver disease leading to acute alcoholic hepatitis. Dr. Kishore, what's your take?
Sir, it will be a very practically a very small subset of patients which would actually qualify for this. If you look at the Lilly criteria and decide whether you want to transplant them, but generally it should be two things. One, we should be very sure that patient was not aware that he had liver disease when he was drinking and got acute alcoholic hepatitis, because that if that is there, then it means that there is harmful drinking despite knowing liver disease. So the chances of having recidivism is very, very high. That is one. And second thing is, patient should not have multi-organ failure, or the MELD score should be preferably not very high. So, I mean, it's a very gray area. We haven't transplanted any with acute alcoholic hepatitis. It's there in the books. I don't think in India also there are very many centers doing transplants for acute alcoholic hepatitis. It's a
Uh,
little bit of an ethical issue as
yeah,
well.
it's a lot of ethics,
And
lot of
and
debate,
and
and lots of
ACLF also
disagreement.
ACLF is also a different ball game. But acute
Yeah.
alcoholic hepatitis, I mean, I would be very skeptical to transplant them. And in very select subset of patients, maybe you think about it.
So Dr. Gaurav, what's your take on this? Transplanting in.
Yeah, I have a little different opinion on this, and so I agree with that we have to be very selective in transplanting a patient who is acute severe alcoholic hepatitis, and obviously the selection criteria does makes a difference. So obviously we have transplanted at least 4 or 5 such patients, and all of them were young patients presenting with the first episode, and actually they are all high melders. They were not low melders, so they have been given the trials, conservative trials. All of them have failed, and most of them has already have acute kidney injury, high meld, and
High
they
basically they had severe liver disease. That's
sorry,
they all had severe liver disease. That's for the general
all have
audiences.
severe liver disease. So only thing what we do is we have a very frank discussion with the patient and the family. Cadaver transplant option is out. Only option is living donor transplant, and the family and the patient has to understand about the family has to understand the risk of recidivism, and we get them a psychologist and psychiatrist evaluation, and then only we choose those patients. So we have transplanted 4 or 5 patients, and actually we have been following with them till now. None of them have gone back to drinking. But these are the patients which have been very carefully selected. Not all alcoholic severe hepatitis have gone for transplant.
So alcohol always evokes strong emotions, and so
Correct.
whether it is how much to have, should we transplant, there are always ethics, always debate, always queries and questions. But let's move on to some more mundane and boring topic. Something fatty liver. As we grow older, young people will have infections, they'll have alcohol related liver disease. As they grow older, they will have obesity, they will have hypertension, diabetes, and they'll get fatty liver. So, tell us a little more about fatty liver disease. Dr. Arvind, what's your take on prevalence and what do we do? How do we
Yeah.
screen patients with fatty liver disease?
Yeah. So fatty liver disease is fairly common, up to the tune of maybe 20 to 30% also NAFLD, not NASH, but the prevalence of fatty liver is fairly high, and it is normally picked up by doing a routine ultrasound. We do fibroscan only in selected cases where we suspect NASH or severe liver disease, if the transaminitis is severe, or if there is low platelets, or on various indices like the APRI indices. So we are selective. And plus, we would screen people who are obese, basically with high BMIs and with diabetics and with other components of metabolic syndrome. Fairly common problem, but less common than alcohol and hepatitis C. This is my take on this.
Dr. Ajay, what are your take on? One is prevalence, and how would you screen? Would you go ahead and do fibroscan and all?
India being the capital for diabetes worldwide,
No.
and you look at it, two-thirds of diabetics have fatty liver. So I think fatty liver much more than I would see hepatitis C or even alcohol. Fatty liver is spread across all generations. You can see young uh, people, adolescent obese, and you can see as part of metabolic syndrome, and you can see it in the older age group also, where it has reached probably cirrhosis or closer to that. I would screen any patient who does come to me. Specific. We see enough patients who have normal liver function also having a nodular liver, or maybe not be showing a nodular liver but showing very high levels on fibroscan. So fibroscan being a modality which is so simple, any patient who has fatty liver, I would say that yes, if he's got any comorbid along with it, please go ahead and get a fibroscan done. It's more reassuring to get to know about how much of stage of fibrosis is there, and the CAP value tells you a good level of fat in that patient. So I
So,
would
so,
screen them much earlier.
so Dr. Sani, if you want to keep these people with fatty liver healthy, what would be your
Yes.
advice on diet, exercise, alcohol?
Yeah. So alcohol, as we have already discussed, Dr. Pankaj, I would
Alcohol
not
avoid
advise
totally.
it in moderation. So we avoid alcohol, avoid smoking, as it also leads to fibrosis. And in terms of exercise, I normally advise them at least 2.5 hours every week of both aerobic and resistance exercises. This is what I teach them. And in terms of diet, basically to avoid any fried fatty foods, fast foods, basically because of their high calories and high saturated fats. And I would encourage the certain foodstuffs in terms of, say, fruits, vegetables, in terms of nuts, in terms of avocado. These are healthy foods, and coffee also 2 to 4 cups per day, along with vitamin E and vitamin D. So this would be my recommendation basically for a, and plus to control the comorbid conditions like obesity, diabetes, and metabolic syndrome, hyperlipidemia.
So, what would be your advice on weight loss? How much weight do they really need to lose, Dr. Ajay?
Uh,
Uh,
what has been seen is that if you lose 5% body weight, your liver will not worsen. And if you lose 10% body weight or whatever you are, there would be some improvement in your liver fibrosis. So I would go by that. But yes, a person who's morbidly obese, you would recommend much more than that. Anybody who has a BMI of above 40, please would recommend undergoing a bariatric surgery or any kind of a thing to reduce weight uh, properly. So ideal would be a 10% weight loss over a period of time. I wouldn't say that it should happen quickly. It's not that you need to lose weight in 15 days. Rapid weight loss also is not going to be good. So you will have to plan it out. Ideally, 2 to 4 kg per month is a good weight loss program.
That's good. So let us get our surgeon in the picture. So, what are your challenges in transplanting these patients with fatty liver disease? And we are seeing a lot of people who now get liver cancer even without going into cirrhosis. Normally, liver disease progresses to liver cirrhosis, develops cancer, and then you have worsening. But sometimes, without going through the process of cirrhosis, we are seeing a lot of people with fatty liver who are going on to develop liver cancer. So, who are these people? What are your challenges in transplanting people with fatty liver disease and fatty liver disease related liver cancer?
Yeah, you're absolutely right, sir. It doesn't follow the usual progression. Patients need not be cirrhotic before they get HCCs. So, if a patient comes with HCC and NAFLD, so we would first see if the patient is a candidate for resection. But if it is a cirrhotic with HCC in the background of fatty liver disease or NASH, then we would think of transplant. Challenges are twofold. One, usually it is not just the liver. Whenever there is NASH and we usually see it is associated with metabolic syndrome. So we expect diabetes and we expect some cardiac comorbidity and obesity. So this makes the preparation for transplant a bit challenging because we have to optimize the cardiac condition well and make sure that there are no obesity related complications. So usually wound complications and other things are higher in transplant patients. The other side of the coin is in living donors, a lot of people have fatty liver, and we can't accept fatty livers because fatty livers don't grow very well in the recipient and they don't regenerate in the donor as well. So the cutoff for fatty liver generally in living donor transplantation is a macrovascular steatosis of around 10% on biopsy. So if people are overweight, we encourage them to lose weight. Like Dr. Ajay said, we encourage them to lose at least 10% of body weight. We repeat a biopsy, put them on a good diet. In fact, there are papers published on this, and these donors can be optimized. And when their fatty liver reverses, we can take them for transplant.
Sounds good. So, but as we grow older, we many people are worried about the liver, and one of the things people tend to do is take a lot of complementary medicines as liver tonics. So, what's your take on liver tonics, Dr. Sani? Are they of any value? Do they do any harm? What should be the advice? And then there are so many tonics in the market. It's just
Yeah.
mind-boggling.
So, Dr. Pankaj, my advice is very clear. I would never recommend a liver tonic they, according to me, they don't do any good, but they certainly can do harm in terms of drug induced liver injury or herbal induced liver injury like Dilly or Hilly. So I'm not the one who is supporting any kind of liver tonics basically.
So, what happens to the liver as we grow older? You think there are any changes in the liver as we grow older? I think surgeons keep saying that. That's why they refuse all elderly
Yes.
people as donors and recipients. So, anything
Yeah,
in Dr. Kishore?
Yeah, I think the fibrosis keeps increasing. The what we see physically during surgeries, the liver is normally a pliable, nice, soft brown organ. As we see older livers, even for other reasons other than transplant, the liver becomes shrunken, feels a bit firmer than usual. That's because there is fibrosis. It looks wrinkled. So the fibrosis component does increase, and also the regenerative capacity of the liver goes down as one ages. And I think at the molecular level, obviously, all the drug metabolism and all those things slow down with age.
So, and you know, as we grow through ages, we have many family members with liver diseases. Some are infection related, like hepatitis B and C. What about other people? How does genetics play a role in our liver disease? I mean, some are things which happen in children. Let us exclude that part. Exclude the illnesses which are happening in neonates and young children as part of recessive genetic disorders which run down families. But what about other liver diseases? How does really genetics affect them, and how does it affect when we grow older? How much are we seeing this? How many people, one person has cirrhosis in the family, you tend to have no other cause, and you find other people also developing cirrhosis without any obvious metabolic cause. Does it happen?
Uh, I'll answer that question. That yeah, there are families who do suffer from liver diseases. There are families who are, whether it's related to families having alcohol or families having liver which is prone to infections. I'm not talking about just hepatitis B, autoimmune disorders which are there. There are families who have a lifestyle eating habits, who are all of them are obese. I see families who are like, mother, father, children, all in that 100 plus kg group. So they are, I guess, besides just the genetic part, a familial kind of preponderance of liver disease. It could be related to the dietary habits, environment, or genetics, or microbiome. I can't say, but there are groups, and I would like to label them that they're genetically linked, but it's more like seen in that particular family.
Like a genetic predisposition, really, not
Yeah.
a overt genetic basis where it runs down XY, or runs down chromosomes. But very true. But what advice should, if one person in the family has liver disease and cirrhosis, what advice, if there's a person with cirrhosis, for example, what should be the advice to the other family members? Dr. Sani, you have one person, one male
Yeah,
who's 50 years old, he's slightly obese, he's a diabetic, he has cirrhosis. So,
yeah.
what should be the advice to his children who are 30, 35? What should be the advice to them?
Yeah, I advise them for a early screening in terms of routine liver function tests, in terms of routine ultrasound. They may be prone to develop the same disease or more prone to develop HCC also, and plus to lead a healthy lifestyle. So they should be careful that whether they are not following into the same footsteps, they have to be extra cautious in terms of alcohol, in terms of regular screening, and in terms of regular visits. This is what I advise them. They have to be more careful as compared to any family which does not have any established liver disease.
So, what is the advice we give people across different ages? Dr. Raja is a little philosophical. So, you have a young child. If you want to give advice to the mother, be careful about his liver. To a young adult who is promiscuous or who's into drugs, or he's into alcohol, and an older person who's worried, what would be your advice across the generations? What would be your say, taking care of your liver? Let me ask you that.
Okay. So, India now is the third largest country with young obese. We have two spectrums. We have starvation one side, and you have the obesity other side. So I would advise the younger, I mean, parents to have their kids going out of the house to play instead of being locked indoors with video games. lifestyle changes for the children, not eating junk food, eating healthier food. It's like something which is going to come in from the parents going on to the next generation. It'll have to be followed. So that is for the younger people, the children. The young adults who are into socializing, where alcohol is no more taboo, rather it's the norm. I guess you'll have to educate them. They have to be told what are safe limits. They'll have to be told there's something called binge drinking. By definition is if you have 5 drinks or more in a day, it's called binge drinking. Even if you do it once a week, it does as much harm as taking 14 drinks in a week. So it's like you'll have to educate them, tell them about food habits, and then going about the preventive part. Preventive part being that they have to know about what is safe. Hepatitis B vaccination, I guess, is uniform now as part of the EPI. But for Hep C, they have to be told as part of a screening they should do. Should not practice anything which is unsafe. The age group that we are in, the elderly side that we are heading towards, I guess will have to follow what we have followed so far: a healthier lifestyle,
Dr.
eating
Ade,
well.
you're young. You're not the elder, older types. You're young.
I guess
So
I guess
let me
60s,
ask you
60s.
something which we haven't covered so far. We've been covering chronic liver disease. What about acute hepatitis vaccination? What about hepatitis A? And there is a lot of, lot of interest in upcoming possible likely, hepatitis E vaccine as well. So tell us more about these vaccines.
Hepatitis A is going to be a big thing because as our lifestyle has improved, we are seeing more and more of adult hepatitis A because I guess our sanitation and our food habits have improved. Otherwise, before the age of 5, all of us in India used to acquire hepatitis A. So I guess we will have to have the vaccination. The vaccination was already there, but as part of a program, it will be added on. It should be added on to people who have underlying chronic liver disease as a protection because they tend to go into ACLF if they get hepatitis A. So that's one part about it. Hepatitis E is primarily more worrisome in pregnant women where it has a 6 times higher incidence of acute liver failure. But per se, it's still a foodborne hygiene. Food hygiene would be a primary of primary importance. Vaccination for Hep B is still a long way away. I don't think it's there in the pipeline. It'll take a few years, but I guess when it does come, it is going to be there.
So hepatitis E, there are a lot of trials, and they're already being evaluated for DGCI approval, and I think it's already on, and we may hear about it very quickly. So as we look after a liver, our aim is to prevent significant liver disease. But many of these people who have acute hepatitis go on to develop acute liver failure, and some people with chronic liver disease, chronic hepatitis, fatty liver disease will go on to develop cirrhosis and end stage liver disease. So it's not necessarily the end of the road. The transplant is also an option in many of these people. Some of them, when they have severe liver disease and they have, for example, a precipitating cause which we can treat like a autoimmune liver disease, or really more in favor of a hepatitis B and or alcohol, if you prevent the disease which has caused the illness, if you treat that, these people may improve, but many of them will go on to developing uh, end stage disease and require liver transplantation. And that's where we have people like Dr. Kishore coming in. So Dr. Kishore, tell us more about transplant for liver disease, and what is your take on acute and chronic liver disease? How many are seeing, how many are doing, and what's your advice to people who have end stage liver disease and worry about success of liver transplantation?
So for chronic liver disease, the indications for transplant are very well known. So it is decompensated chronic liver disease that we select for transplant. A lot of people are well compensated and they can be managed with medical management. So refractory ascites, which is not getting controlled with the usual diuretics, patients who have developed spontaneous bacterial peritonitis, patients who have developed problems with other organs like hepatorenal syndrome, or HRS-AKI as it's called now, or patients with hepatopulmonary syndrome, or patients with hepatic encephalopathy. So all these patients who have developed end organ damage because of chronic liver disease, these people have a median survival of about 9 months or a year. So these patients should be listed for transplantation when it comes to chronic liver disease. The other important indication, of course, is HCC, which develops in the background of a cirrhotic liver. Again, there are well laid out criteria for patients with HCC who will be candidates for a transplant. The essential idea is to not select patients who have too much of advanced disease so that they don't recur and they have a good survival advantage. In India, the UCSF criteria is what is accepted for HCC and therefore listing for transplantation. So that is about chronic liver disease. Coming to ACLF or acute on chronic liver failure, these patients are much sicker than a decompensated chronic liver disease patients. And usually ACLF with organ failure, which is like one or two organ failures, can be taken up for transplant. But ACLF with multi-organ failure or very high MELDs or with infection or multi-organ dysfunction, they don't do well. So ACLF is a very gray area and patient selection is very, very important. The third category of patients after chronic liver disease and ACLF is ALF or acute liver failure. Here we all follow the King's College criteria. These are quite well known. So patients who fit into the King's College criteria have a transplant-free survival of about 20 to 25%. So almost 80% of people who fulfill King's College criteria will need a transplant. So these are the broad indications medically for liver transplants. And about success, I think in modern day practice, I think the 1 year survival is well above 90% in all centers, including ours. So we have good survival rates, in fact, much more than 90%. We are a new program here in Bangalore, so we've had actually 100% success. But I wouldn't count that because it's all statistics. I would just stick with the world statistics, which says that survival at 1 year is about 90%, and survival at 5 years is about 70 to 75% across all indications. So transplant is a safe procedure and it requires multidisciplinary input, and that's what makes the program successful.
Thank you. So I'll sort of summarize what the panel has raised. If you have to look after your liver across the lifespan, we must be careful of, first and foremost, is be aware of hepatitis B and hepatitis C. You must, if you are at high risk, you must screen. If you have blood transfusions, if you've had surgeries, if you have somebody else in the family who has these viruses, you must screen yourself. So screen, identify, and treat early to prevent morbidity from liver disease because of viruses. The second is alcohol should be in moderation if it cannot be avoided altogether. And people who have comorbid diseases like diabetes or obese, even small amount of alcohols are not safe. Fatty liver is a challenge with the increasing amount of obesity and metabolic syndrome in our country, and diet and exercise are the cornerstone of management. You have to lose about 10% body weight. The exercise should be about 45 minutes of aerobic exercises at least 5 days a week. And if you do resistance exercises 1 hour twice a week, in addition, would be beneficial. Lose weight, control diabetes, diet, healthy diet. These are all important things. Also, be careful of avoiding liver tonics. They often may cause liver damage, and people we see many people with tonics during COVID era having come in with liver failure after these tonics. And if liver disease is advanced, transplant is already and always an option, but our aim should be to keep people away from transplant. I think if there are any questions from the panel or any comments from the panel, I would welcome those before we wind up. Anybody? Well, there seem to be none. So we have had a wonderful panel discussion. I think we'll wind up here. And thank you, everybody. Thank you, Dr.
Thank you.
Kishore, Dr.
Thank
Bhalla. And
you.
thank you so
Thank
much
you, Dr.
for
Pankaj.
the
Thank you.
wonderful.
Thank you.
Thank you to everybody. Thank you.
We'll wind up here. Bye, sir.
Thank you. Bye bye. Bye. Bye.